Good evening, everybody. In today's lecture, let us try to learn about breast cancer. This is the 21st day of our 30 days oncology and chemotherapy course. So, in today's lecture, let us try to learn everything about breast cancer, the chemotherapy of breast cancer, and treatment strategies, anatomy to treatment. Okay. So, we'll discuss all pathophysiology, etiology, classification, clinical presentations, and diagnosis and AGC staging of breast cancer and all other concepts associated with breast cancer in detail. So let's begin our session. So before understanding about the breast cancer, let me tell you few important points about breast cancer. First thing, breast cancer is very common in women. One important point you have to remember, breast cancer is very common in women, and it is very common in patients who are above 50 years, particularly in the patients who are having menopause. So menopausal women are having greater risk of causing breast cancer. And next important point you have to remember, see, breast cancer is mainly caused due to the overexpression of certain genes and certain receptors. In that we have three receptors. Always remember, overexpression of estrogen receptor, overexpression of progesterone progesterone receptor, and overexpression of HER2 new receptor. So these three are very important. Overexpression of estrogen receptor, progesterone receptor, and HER2 new receptor. These three overexpression is having higher risk of causing breast cancer. So one is gender, female gender. Number two is age, above 50 years, particularly menopause. And number three, genetic factor, HER2 overexpression, progesterone receptor activation, overexpression, or estrogen receptor overactivation or overexpression. So these are important points always you have to remember while discussing about breast cancer. So in this session, we will discuss about epidemiology of breast cancer, and we will discuss a few basic points about anatomy of breast, because unless you understand the anatomy of breast, we can't understand the pathogenesis and clinical presentations. Along with this, we'll discuss how breast tumors are formed, breast tumors and different morphological types and structures of breast tumor. Along with that, we'll discuss the etiology, risk factors, different causes of breast cancer. We will discuss in detail about pathogenesis. Actually, pathogenesis we have already discussed in previous classes, how cancer cells are proliferated and how neoplasm is developed. Okay, we will discuss about pathogenesis in brief. We will discuss about the classification, because classification is important in treatment. Based on the classification, we have treatment. And yeah, after classification, we'll discuss clinical presentations, what signs and symptoms patient will develop. And we have AJC staging. We'll discuss about staging. And we will discuss finally the management of breast cancer. Actually, in breast cancer management, we have three strategies. Number one is we have surgery, we have radiation therapy, and we have adjuvant chemotherapy. In chemotherapy, we have few chemotherapeutic strategies, regimens. We'll discuss that in detail in stage 1 and stage 2 and different stages of breast cancer. Okay, so these are different concepts we'll be covering in this lecture. Now let's begin in detail about the epidemiology. Okay, epidemiology epidemiology of breast cancer. As we have already known, uh, breast cancer is most common in women. It is very commonly seen in women. Not only women, it can also be seen in men. You have to remember this. Breast cancer also can be seen in men, but it is very prevalent in women. If we see the ratio between men and women, and women and men, in men and women, if we see one man is affected in every approximately 150 women. So 1 is to 150 is the ratio of affecting breast cancer in men. Okay. And one point, it is very common in women. We have already discussed this. And it is usually affected to postmenopausal patients. Postmenopausal, actually, it is not exactly seen after menopause, but it can also be seen just before menopause. Particularly, we call it as perimenopausal women. So before menopause, during menopause, or after menopause. Okay. So around menopause, it can be seen. Okay. So, but more commonly, it is seen in postmenopausal women. And most of the time, these cancers are adenocarcinomas. Adenocarcinomas are glandular cell cancers. I will explain about all why it is called adenocarcinomas. Okay. In anatomy and physiology and anatomy, I will tell you. And see, there is one international agency for research on cancer in 2020. Uh, According to this data, it states that uh, patients who are having cancer, especially breast cancer, in that uh, the worst cases were seen in patients who are menopause, menopause, and it is very very common in women. Okay, and in upcoming days, it is going to affect most of the women who are in developed countries. In developed countries, particularly in Europe, America, and in few other developed countries. In these countries, it is very commonly. And see, in 2023, if we see new cases, 297,790 new cases are estimated. Okay, and these many cases are diagnosed in 2023. Just you can see the data, how many cases are newly diagnosed with breast cancer. Okay, and here this is the old data actually. In 2001 and 2003, there is one research conducted in this. It is a research surveillance epidemiology and end results. In this SEER result, it was found that based on the age, actually this data is based on the age. When they when they studied in the females between 30 to 40 years, they found that in every 233 patients, one female is affected. And in between 40 to 50, one patient is affected in 69 patients. And in patients with from 50 to 60, one is affected in 38. And in between 60 to 70, one patient is affected in every 27 cases. So as age is increasing, the incidence of cancer is also increasing. And if we see the uh, age interval between birth to death, in between birth to death, every one patient is affected in every age. So in lifetime, in every 8 women, one woman is affected with breast cancer. You can just imagine the data. So once in a lifetime, in every 8 women, one woman is affected with breast cancer. So these are the different studies and surveys which are undergone on breast cancer and the epidemiological data. And yes, if you see the incidence in females, the major contributing cancer is breast cancer. Okay, so breast cancer stands on the first position, and next to breast cancer we have lung cancer, and next to that, third position is given for colorectal cancer, and after that prostate cancer. Actually, if you see particularly in males, the most commonly affected is lung, and then colorectal, and then prostate. Okay, but this is overall, this data is given in both males and females. Okay, so in males and females, if we club the data, breast cancer will stand on the first position. Particularly in males, if you see, lung cancer will be on the first position. And in mortality rate, you see, lung cancer are standing on the first position. Lung cancer cases will stand on first position because lung cancer is causing most mortal cases. And next to lung cancer, we have colorectal cancer, and next to that, we have liver cancer, and then stomach, female, breast cancer, esophageal cancer, pancreatic, prostate, cervical, and leukemia. Leukemia stands on the last. Okay, leukemia cases, death cases are very very less because we have very effective treatment for leukemia. In previous classes, we have already discussed. Okay, and see, after prostate cancer, if you see the incidence in patients, stomach cancer, liver cancer, esophageal cancer, cervical cancer, thyroid, and bladder cancer. Bladder cancer stands on the last. Okay, so these are different data about incidence and mortality of different cancers, and here just try to focus. Breast cancer is standing on the first rank. Okay, on the first position. That's what I want to tell you. Breast cancer is the major contributing cancers in all other cancers. And in mortality, Anyways, mortality, it is not that much mortal when compared with the lung, colorectal cancer, and liver cancer. Okay. Now, let me tell you some basic points about anatomy of breast. See, just imagine this is a breast. Okay. So each breast has approximately 18 to 20 lobes. It has 18 to 20 lobes. Just imagine this is one lobe, this is another lobe. Like this, we have 18 to 20 lobes. So each breast is divided into lobes. Actually, these lobes are epithelial tissues. Lobes are epithelial tissues. And in between these lobes, we have connective tissue, which is also called stroma. Stroma, stroma area. Okay, stromal tissue. And this stromal tissue is mainly composed of. It is mainly composed of connective tissue, and adipose tissue. Adipose tissue. In between these lobes, we have stromal tissue, which is made up of connective tissue and adipose tissue. Now you see, if we take one lobe, just try to imagine. Just let me draw one lobe here. Yes, it is a one lobe, and this is a duct. Okay, lobes are each lobe is connected with a duct, and this duct is called lactiferous duct. Lactiferous duct. Each lactiferous duct is opening near the nipple. Each lactiferous duct is opening near the nipple, and from the nipple it is associated to the lobe. This is lobe, and this type of lobes we have 18 to 20 in each breast. So each lobe is having different lobules in its lobe. Each lobe has different lobules, and all these lobules are connected again with a small duct, which is called terminal duct. Terminal terminal duct. This is terminal duct. Terminal duct is associating with the major duct, which is lactiferous duct. Okay, so each lobe is having minute, again minute lobules. Okay, each lobe has lobules. In this, just imagine this is a lobule. Each lobe has various lobules, and in the lobule there is one basic unit which is called acini, acini. Okay, just I will make you very easy to understand. Don't confuse, it is very easy. Just imagine this is a breast. In breast we have lobules, right? These are lobules. We have 18 to 20 lobules, right? These lobule, sorry, they are lobes. Okay, 18 to 20 lobes. Each lobe has lobules. Each lobules has acini. So acini is the finalmost unit finalmost unit of the breast. Group of acini will form a lobule, and group of lobules will form a lobe, and group of lobes will form a single breast. Okay, very simple. See, all these lobes are connected with the lactiferous. Actually, this is called lactiferous duct, and when this lactiferous duct is just, it is trying to open at the nipple, here we have one sinus bulged area, which is called lactiferous sinus. Okay, so this lactiferous duct is leading to lobe, and in this lobe it is leading to terminal duct. Okay, terminal duct is leading to lobule. Now see, here we have, this is a lobe, this is a terminal duct is leading to lobule, this is a lobule. Okay, now you see, we have one single one single unit of the lung, which is called acini. group of acini Group of acini is called lobule, and this group of lobules forms lobe. And like these lobes, we have 18 to 20 in each breast. Okay, so this is very easy. I think you understood the composition of breast. Breast is composed of lobes. These lobes are epithelial cells. and in between these lobes we have stromal tissue, which is made up of connective tissue. That also we have understood now. So I'll just try to make you very easy now. You see, just try to understand. Each breast is having 18 to 20 lobes. Just imagine this is a lobe. Okay, all these lobes are connected with lactiferous duct. All these lobes are connected with lactiferous duct. Lactiferous duct is leading to one bulged area which is called lactiferous sinus. This bulged area is lactiferous sinus. Lactiferous sinus is again leading to nipple. And this uh, hyperpigmented area, the colored area, hyperpigmented black, brown colored area, this area is called areola. Areola is the black color. Just imagine this our breast. In breast we have black color spot which is leading to nipple. So this black colored spot is called areola. Okay, you understood what is lobe, lactiferous duct, areola, nipple, and lactiferous sinus is the bulged part of the lactiferous duct. Okay, each lobe is made up of lobule, and each lobule is made up of acini. Okay, acini is the basic unit. Okay, clear? So this is very very easy. Now let me try to draw one acini and its transverse section. Okay, acini is the basic unit of lobules, right? If we see the transverse section of acini is made up of a basement membrane. Initially, it has a basement membrane. This is very very important. This is very important to understand. Okay, on the breast there is a basement membrane. Outermost layer of the acini is basement membrane. Just inside the basement membrane, there is one epithelial layer which is called. There is one epithelial layer just inside the basement membrane. There is one epithelial layer which is called myoepithelial. These cells are called myoepithelial cells. These cells are called myoepithelial cells. These myoepithelial cells are present just inside the basement membrane. These myoepithelial cells are also called as basket cells. Basket cells, or they are also called as spider cells. Spider cells. These cells are very very important. Basket cells, spider cells, myoepithelial cells. All these are same. These cells are mainly they are activated they are activated upon oxytocin, and they are activated upon prolactin, and with that what they do, they will produce milk. So milk producing epithelial cells are myoepithelial cells, and just inside there is one more layer just inside the myoepithelial cells there is one thin layer. This layer which is inside the myoepithelial layer, this layer is these cells are luminal cells. These cells are called luminal cells. Okay, and the secretions which are secreted by these myoepithelial cells will enter into the lumen, so it is filled in the lumen. And these luminal cells also produce some secretions which are uh, stored in the lumen, and this lumen is leading with terminal duct. All the acini terminal ducts will associate together, and they will form a lobule, and all these lobules will go and associate with the lactiferous duct. Okay, I think you understood. Now let me see, just try to understand. This is the transverse section. Just imagine this is a lobule. If we cut the lobule in TS transverse section, just try to see, this is one acini. This total area is the acini. Acini is covered with a basement membrane, topmost layer, basement membrane. Inside the basement membrane, we have one layer of cells, epithelial cells called myoepithelial cells. These are myoepithelial cells. Okay. Just outside to this, we have basement membrane. This is basement membrane. Basement membrane, myoepithelial cells, and inside myoepithelial cells, we have luminal epithelial cells. These are luminal epithelial cells. This one. And inside this is lumen. Okay. This is lumen, which is filled with milk or eosinophilic secretions or other secretions. Okay, so actually in breast cancer cases, we can find two types of breast cancers. Mainly 90% of breast cancers are seen in epithelial cells, and remaining 10% is seen in connective tissue. In this, see, 90% of epithelial cells Here, actually, in epithelial cells, we have two types of epithelial cells. One is epithelial cells in acini. In acini, we have epithelial cells. In acini, we have two types of epithelial cells. One is myoepithelial cell and luminant epithelial cell. This acini is leading with the duct, terminal duct we have, lactiferous duct we have. These ducts are again made up of epithelial cells. These ducts are also made up of epithelial cells. So we have two types of epithelial cells. One is acinar epithelial cells, which are present in the acini, and ductular epithelial cells, which is present in the ducts, terminal duct, lactiferous duct, and all those ducts. Okay. So 90% of the cancers which are seen in the breast are epithelial cell cancers. That's why these epithelial cells are glandular cells, because these glandular cells are secreting something. They are producing some secretions. That's why they are called glandular cells. That's why most of the breast cancers are called adenocarcinomas. Okay, breast cancer is adenocarcinomas. Just previously we have discussed all these points. Now you see, actually, if you see the breast tumors in the breast of the females, there are three types of breast tumors. One is fibroadenoma, and second one is phylloids tumor, and third one is intraductal papilloma. Intraductal papilloma are the cancers which are seen in the ducts. Okay, in the ducts, they are seen in the ducts. Phylloids tumor are particularly seen with connective tissue, and fibroadenoma are seen. These are also can be seen in duct cells. Now you see, if you see the first one, fibroadenoma, the first breast cancer or breast tumor, these are mostly they are benign. Fibroadenoma or adenofibroma is a benign tumor of fibrous and epithelial elements. This can be seen in both a fibrous and epithelial tissue. Now, see in fibroadenoma, if you see morphological features, this fibroadenoma is they are usually small, 2 to 4 centimeter in diameter. They are solitary, well encapsulated. They are well encapsulated and spherical or discoid mass. See, here we have two types in fibroadenoma. One is intracanalicular pattern tumors. Actually, see, just now I told there are ducts, right? Terminal duct and lactiferous duct. For example, just imagine this is a terminal duct. This terminal duct, this terminal duct is having epithelial cells. Epithelial cells. These epithelial cells of the duct, they are proliferated. They are proliferated, and what they do, this proliferation of these ductal epithelial cells will try to, they will try to close the lumen of the duct. The lumen will be closed. Lumen will be closed. See, you can see this total duct lumen is totally closed. It is tightly encapsulated. Okay, these are intracanalicular pattern type of fibroadenomas. Okay, somewhere lumen is visible, but in some places lumen is totally closed. Lumen is totally closed because they are intracanalicular. Between the canaliculi they are developed. Okay, these tumors are developed. And the next one, fibroadenoma, is pericallicular pattern. Pericallicular pattern in here, actually the lumen is not closed, but the epithelial cells are having well encapsulated layer. Okay, cells are seen. These are pericanalicular pattern, and these are intracanalicular pattern. These are present inside the canaliculi, and these are present in the epithelial cells of the canaliculi. Okay, so these are about fibroadenomas. And the next one, the second one is phylloids tumor. Second one is phylloids tumor. Just now I told phylloids tumor are mainly the tumors of connective tissue in the breast. And if you see the morphological features of the second phylloid tumor, most of them are big. These tumors are enlarged, and their diameter is up to 10 to 15 centimeter. They are round to oval. They don't have specific shape. They are mostly bossulated. Bossulated means they are in their size is totally enlarged. Okay, bossulated. They are bulged, and they are less fully encapsulated than fibroadenoma. Actually, fibroadenomas are encapsulated, but these are not encapsulated. They keep bulging. They keep increasing their size. Okay, and if we cut the surface, we can see the gray, white, and cystic cavities, areas of hemorrhages, necrosis, and degenerative changes can be seen. And mostly these are connective tissue. Just let me show you the image of phylloids tumor. Phylloids tumor was first nomenclature given by Muller. Okay, in 1838. These are bulky breast tumors. Okay, and they are leaf-like structures, and their appearance is like leaf-like structure, and they are having aggressive clinical behavior. So in these tumors, Actually, these are benign type. Few are malignant. Few are malignant, and sometimes if this tumor is not removed completely surgically, they can uh, cause malignancy. They can affect to other areas, particularly to pancreas, lungs, and also to liver. Okay, so this phylloids tumor is removed by surgery. They are easily removed by surgery. Okay, so this is the second type of phylloids tumor, and third type is intraductal papilloma. Third type of tumor is intraductal papilloma. Just I'll try to show you this intraductal papilloma. These are mainly present near the nipple areas. Okay, so intraductal papilloma, these are benign papillary tumor occurring most commonly in usually in lactiferous ducts. Just now I told you the lobes are leading with lactiferous tubule, and this lactiferous tubule is leading to nipple. Okay, so the tumors which are seen in these tubules particularly, so they are intraductal papilloma. Okay, these are usually solitary, small, and less than 1 centimeter. They are less than 1 centimeter in diameter, commonly located in major mammillary ducts close to nipple. They are very close to nipple. Actually, the cancers which are present near the nipple with the extravasation and extra growth, that is called Paget's breast cancer or Paget's breast, that we'll discuss in next coming slides. Okay, Paget's breast is different and intraductal papilloma is different. Intraductal papilloma is mainly seen in the lactiferous tubules, and these are mainly benign. Okay, these are mainly benign. So these are three types of benign tumors. In benign tumors, what we have discussed about fibroadenoma. These are fibroadenoma are mainly present in the tubules, especially in the terminal tubules and inside the acina. And phylloids tumor are the tumors of the connective tissue, and intraductal papilloma are mainly seen in the lactiferous tubules, lactiferous tubules. Okay. Now, if you see the etiology of breast cancer, mainly as I told, age above 50 years, gender female is very common, and I have already discussed one in every 8 women in lifetime, starting from the birth to the death. We can see one in every 8 women. Anyways, this is controversial epidemiological data that we have seen. And overall, if you see, there are two major etiological factors. One is hormonal factor and one is genetic factor. I'll try to explain these in detail. Before that, if you see some other etiology, other factors, family history plays very important role. First degree relatives, if patient's mother, sister, daughter, if they are affected, if they are having breast cancer, their children or their patients are having greater risk of causing breast cancer. Okay, blood relatives who are having breast cancer, and people who are having cancer at younger age will develop breast cancer. Bilateral cancers, one both the tumors are affected with breast cancer, their children are having greater risk. And high risk cancer families having breast and ovarian cancers are also greater risk. So family from the family, anybody, brother, sister, mother, daughter, anybody are having breast cancer, they are having greater risk of causing breast cancer. And menstrual and obstetric history, this is very, very important. Total length of menstrual life is directly related to increased risk. For example, you see, if patient's menarche, menarche is very early, I mean, if females who developed menarche at age 10, and if they are having menopause very late, okay, the duration between menarche to menopause, if this duration is if this duration is more, that type of patients are having greater risk of causing breast cancer. That means menstrual life, length of menstrual life, length of menstrual life is having direct relation with breast cancer. Okay, and there is increased risk of breast cancer development in women who had early menarche and who had delayed menopause, and also women who are having nulliparity. Nulliparity are the women who are not having pregnancy, who are not having babies. Okay, nulliparity women, late age first childbirth. Okay, if woman is giving childbirth at late age, like at 30 years or at 31 years, 35 years, first childbirth at 30 or greater than 30, even they are having greater risk. And patients who are having fibrocytic changes in their breast, even they are having risk of causing cancer. And some miscellaneous factors like cigarette smoking, females having habit of cigarette smoking, high amount of animal fat diet, high calorie diet, alcohol consumption, breast augmentation surgeries to improve their breast size and to increase breast size. We have breast augmentation surgeries if they are having this type of surgeries. High breast density, if anybody has high breast density like fibrous tissue, more density is there, less fat and high density, they are having high risk. And exposure to ionizing radiation during breast. Okay, so alcohol, high fat animal diet, smoking, high density of breast, and breast augmentation surgeries, all these are risk factors for causing breast cancer. And if you see the pathogenesis, just now I told you there are two main factors, one is hormonal factor and one is genetic factor. I'm going to explain about the hormonal factor which causes breast cancer. Everybody should listen very carefully now. See, in hormonal factor, just now I told women with prolonged reproductive life, women with prolonged reproductive life, they are having greater risk of causing breast cancer. Women starting from 15 years to 45, 50 years, up to 50 years, they keep on giving birth to child. Okay, some people what they do till their menopause, they will be just giving birth to their children. Like they will have 15, 20 children. So women with prolonged reproductive life, they are having higher risk. And one more very important point, just now I told unmarried women, unmarried women are having very late deliveries or having late childbirth or having nulliparous. If they are nulliparous, those who are not giving birth, that patients are having hormonal imbalances and they can cause breast cancer. And women with first childbirth and late age over 30, that is also one important. And if patients having bilateral bilateral oophorectomy oophorectomy or removal of ovaries, bilateral removal of ovaries, they are having higher risk of causing breast cancer. Very very important point this is. Bilateral removal of oophorectomy, bilateral oophorectomy we call it, removal of ovaries on from the both the sides, they are having greater risk. And patients who are having ovarian cancer, ovarian tumors or ovarian cancer, and very very important hormonal factors, patient on hormone replacement therapy, patient on chronic oral contraceptive therapy, patient or particularly men who was treated with estrogen, men who are treated with estrogen, they will have risk of causing breast cancer. In men actually we have prostate cancer. For prostate cancer we sometimes use estrogen regimen. So if patient is using estrogen regimen in males, they are having risk of causing breast cancer because estrogen overuse or estrogen can cause breast cancer. Very very important. Estrogen preparations, estrogen overuse, overactivity of estrogen will cause breast cancer, remember this. Okay, so these are hormonal related factors that will cause breast cancer. Now let me talk about genetic factors. Always remember this is very important. Genetic factors. See, in previous class what I told, we have oncogene which induces proliferation of cells and that causes cancer. We have tumor suppressor genes. These tumor suppressor genes will produce certain proteins which will protect or which will stop formation of cancer cells, or it will stop proliferation. It will stop proliferation. These proteins will stop proliferation. These are called tumor suppressor genes. Okay, tumor suppressor proteins. In tumor suppressor proteins, mainly in females, if you see, there is one very important tumor suppressor gene which is called TP53. We call it P53. Okay, P53. This is important tumor suppressor gene. Along with this, we have BRCA1 and BRCA2. BRCA1 and BRCA2. This BRCA1 gene is present on the BRCA1 gene is present on the 17th chromosome. 17th chromosome of our genes, and it will produce certain proteins. It will produce certain proteins which are having tumor suppressor activity. Okay, and along with BRCA1, actually BRCA2 is another gene. This is present on the 13th chromosome, and this also produces certain proteins. These proteins also has tumor suppressor activity. Okay, so TP53, BRCA1 and BRCA2, these three are very, very important protective agents, protective genes which are present in our body. If mutation occurs in P53, there is mutated proteins can't cause tumor suppression activity. Okay, mutation in P53, mutation in BRCA1, VRCA BRCA1, mutation in BRCA2. These three mutations, if mutation in P53, BRCA1 and BRCA2, they will decrease the production of proteins which are having tumor suppression activity, and with that, patient will have higher risk of causing breast cancer. So this is genetic. Along with this, we have mutation in CHEK2 gene. There is mutation in PALB2 gene, and there is mutation in PTEN and ATM. So all these are genes which are associated with causing breast cancer. So just try to remember the uh, mutation in P53, BRCA1, BRCA2. All these will cause breast cancer. So there are genetic causes for breast cancer. I think you all are following me. Okay. Now let us see some general features and classification of tumors. See, always remember breast cancer. Actually, see, if you see the breast is mainly divided into four quadrants. Number one, this is upper outer quadrant of right breast, and this is upper left quadrant, upper, what we can say, upper outer left quadrant. Okay, and this is upper inner quadrant, left and right. This is lower inner quadrant and lower inner quadrant, right and left. This is fourth part is lower outer quadrant in the left area and in the right area. Okay, so these are four different quadrants. Always remember the left breast, upper outer quadrant of left breast, upper outer quadrant of left breast is in this area. It is having greater risk of causing tumors. So always while examining the breast in the females, we have to keenly monitor this area. Okay, because it is having greater risk of causing breast lump formation, tumor formation. Okay, and remaining areas are 10, 15, 20%, but major contributing area is the left outer upper outer quadrant. Okay, this is very important. And yeah, we can see the classification of different breast cancers. Actually, see, in breast cancer, this is little bit important. In classification of breast cancer, we have two main types. One is non-invasive. For example, just imagine this is a terminal uh, duct, and this is acini. Acini and terminal duct are having basement membrane, and they are made up of epithelial cells, right? Epithelial cells. Epithelial cells. If tumor is formed in these epithelial cells, they are not invading to the other tissues. They are not invading to the other tissues. They are called non-invasive. In situ means they are present in the basement membrane itself. Just now I told acini is covered with a basement membrane. If tumor cells are present inside the basement membrane, they are called in situ. So they are non-invasive. They are not invading. They are not crossing the basement membrane. They are not crossing basement membrane. They are called non-invasive carcinoma. In non-invasive carcinoma, we have intraductal and we have lobular. Intraductal means they are present inside the ducts, and lobular carcinoma means they are present inside the lobes. Okay, these are non-invasive carcinoma. And in invasive carcinoma are those carcinoma which are invading from the tissues. They are invading from the tissues. So in that, infiltrating duct carcinoma, from the duct they are infiltrating, okay, and infiltrating lobular, from the lobes they are infiltrating, and tubular carcinoma in the lactiferous tube, from the lactiferous tubes they are invading, and medullary carcinoma from the medullary area, colloid carcinoma and other types. All these are invasive carcinomas. Okay, so non-invasive are present at the localized area, invasive are invading to the other tissues, and in invasive carcinoma also, the first one, infiltrating duct carcinoma, the carcinoma which is traveling from the ducts, they are approximately 80%. They are very very common. Remaining are less common. And the third category is Paget's disease. This Paget's disease of nipple, this is present outside the breast. Outside the breast, particularly it is seen at nipple. It is present at nipple. That is Paget's disease. Okay, the carcinoma which is extravasated, which is present outside the breast near the nipple area, is Paget's disease. Okay, now you see Paget's disease of the nipple. It is the eczymatoid lesion. It is like eczymatoid lesion of the nipple, often associated with invasive or non. It may be invasive or non-invasive ductal carcinoma. Okay, this you can see the nipple bears a crusted scaly. The nipple bears crusted scaly and eczomatous lesion with the palpable subareolar mass. Okay, of the breast. You can see the Paget's disease of the nipple here. You can see the crusting of the surface of the nipple here. It is Paget's cells here. We have Paget's cells in the surface of the epithelial nipple. Okay, so this is the Paget's disease of nipple. Third type of, always remember we have non-invasive. In non-invasive we have intraductal and lobular, inside the duct and inside lobes. They are not invasive. They are present inside the basement membrane only. And in invasive type we have different types. And the third one is Paget's disease, which is present at the outside the nipple area, okay, which is called Paget's disease of the nipple. These are three main types of cancers which are seen in the breast. Now you see, if you see the molecular level and all, we have different types of cells and all. These all molecular level cells and histological classification. All these, it's not necessary for us. In clinical presentations, always remember the patient may not have any symptoms, because breast cancer may be detected asymptomatic patients through routine screening mammography. Generally, most of the breast cancers are not having any symptoms. Okay, if we see the local signs and symptoms, sometimes painless, palpable lump can be seen, lump formation can be seen. Sometimes pain can be seen, nipple discharge can be seen, retraction, dimpling. Okay, skin edema, redness, warm. These all signs, local signs can be seen. Palpable local regional lymph nodes may also be present. And if you see the signs and symptoms of metastasis, various depending on the said metastasis, but may include bone pain. They may cause bone pain, difficulty in breathing if it is affecting to the lungs, abdominal pain if it is infecting to the pancreas, and they may also cause jaundice or mental status changes if it is entering into the other tissues. And in laboratory test, what happens? Tumor markers such as cancer antigens will be positive, and carcinoembryonic antigen CEA will be positive, and patient will have hyper elevated elevation of estrogen progesterone receptor, and HER2 receptors. All these will be activated. Okay, they are positive. Alkaline phosphate or liver function test sometimes will be elevated. Okay, all these they can be elevated. Other diagnostic mammography is always suggested. If patient is in along with mammography, you can go with ultrasonography or MRI, CT, X-ray. We can go, and biopsy is very very important. Okay, biopsy should be done, and identification of tumor, estrogen receptor, progesterone receptor, human epidermal growth factor, HER2, all these receptors are identified. Okay, and sometimes systemic staging based on these radiation, radiography and CT, MRI scan. We have to go for identifying them in different categories. Okay, these I have taken from the older textbook. Now we see the diagnosis. See, first clinical examination should be done, physical examination, palpation, and all. Always remember there is one technique called triple technique in breast cancer. Triple technique. In triple technique, first palpation should be done. If you find any palpation, any disorder in that, if you identify some abnormality, we have to go with mammography. And in mammography, if you find any abnormalities, final aspiration should be done, which is biopsy. And then if there is some identification, we will diagnose the patient as breast cancer, and based on their morphology and based on their location and based on their metastasis and all, we'll categorize them into different types. Okay, so clinical breast examination, breast imaging, magnetic MRI, CT, X-ray, biopsy, all this should be done. Initially screening, we have to perform suspected diagnostic patients. What we have to do, we have to go for mammography. Okay, in mammography, if it is suspected, we have to go for confirmatory tests like histopathological tests, biomarkers, K67 estrogen receptor, progesterone receptor, and HER2 receptor, and gene expression. All these things we have to perform, and we have to go for final diagnosis. Okay, so these are different points about diagnosis and all. Now we'll try to discuss about staging. Okay, this is very very important. In staging C, we have stage TIS, which is normal. Actually, this is normal. In situ carcinoma, in situ lobular intraductal Paget's disease of the nipple without palpable lump, this is stage TIS. And in stage 1, see, tumors are seen, but tumors are less than 2 centimeter, 2 centimeter or less than centimeter in diameter, and no nodal involvement is seen. That is stage 1. And in stage 2, the tumor size is greater than 2 centimeter and less than 5 centimeter, and regional lymph nodes are involved. In stage 3, we have stage 3A and stage 3B. In stage 3A, tumor size is greater than or equal to 5 centimeter in diameter, and regional lymph nodes involved on same side. And in stage 3B, tumor size greater than 5 centimeter in diameter, and supraclavicular and infraclavicular lymph nodes are involved here in stage 3B. And stage 4 is the stage where tumors of any size with or without regional spread but with distant metastasis to other tissues, it is affected. Okay, so this is stage 4, which is very stage 3 and stage 4. Actually, these two are very challenging. It is very difficult to treat this stage 3 and stage 4. Stage 1 and stage 2, here we can simply go with surgery, and along with surgery we can go with chemotherapy, adjuvant chemotherapy. And surgery and chemotherapy, here actually for stage 1 we have 80 to 90%, 80% of simple surgery can treat this patient. And in stage 2, surgery plus chemotherapy has good prognosis, but in stage 3 and stage 4 it is very difficult to treat and prognosis is very less. Okay, we have BIRADS categories. Actually, here if you see BIRADS category, we have 7 categories starting from category 0 to category 6. BIRADS category 0 indicates, actually these are used for diagnosis purpose. Okay, in diagnosis purpose. In BIRADS category 0, uh, actually there is no sufficient information is seen in that radiological data. So need additional imaging or prior examination is needed here, and management recall for additional imaging. More imaging is required here. And in category 1, actually there is no positive of tumor. Tumor suspicion is negligible here. No tumors are found. And in category 2, benign tumors are seen. Routine screening can be done in next visit. And in category 3, probably these are benign. Short interval follow-up should be performed within a month or in a 2. And fourth category of BIRADS category value, this is suspicious. Okay, tissue diagnosis is required here. And fifth is highly suggestive malignancy. Here, malignant tumors are seen in stage 5, in category 5. And category 6 BIRADS category is that patient is having proven uh, carcinoma. Okay, here uh, cancer is confirmed. Now, if you see the management, in the management of breast cancer, see, according to stages, we have to monitor, we have to manage the patients. In stage 1, if you see, here surgery is the drug of choice. Surgery is drug of choice for stage 1. If patient is having Paget's breast cancer, or if patient is in stage 1, so in this case, surgery itself, single surgery can cause 80% success rate. So in if anybody is having stage 1 means, just now I told, stage 1 or those patients who are having tumors 2 centimeter or less than 2 centimeter and no nodes are involved here. Okay, and here if you see the stage 2, in stage 2, actually 2 to 5 centimeter 2 to 5 centimeter diameter of the tumors are seen, and here nodal involvement is also can be seen. So here what we have to do, we have to go with surgery plus 6 cycles of adjuvant chemotherapy should be given. So in adjuvant chemotherapy, we have two strategies. One is CMF protocol, or we can go with FAC protocol. In CMF protocol, we have cyclophosphamide, we have methotrexate, and we have 5-fluorouracil. Okay, 5-fluorouracil. So this is CMF protocol. If CMF protocol is not advised, or if patient is having adverse effects related to this, we can go with FAC strategy. Here in FAC strategy, we have fluorouracil, we have doxorubicin and cyclophosphamide. This strategy is FAC. So in stage 2, surgery plus 6 cycles of adjuvant chemotherapy should be given, and in 6 cycles of adjuvant chemotherapy, we can go either with CMF protocol or FAC protocol. In CMF protocol, what we have cyclophosphamide, methotrexate, fluorouracil, or FAC fluorouracil, doxorubicin, and cyclophosphamide. And if this strategy is not effective, we have alternative. 4 cycles of doxorubicin and cyclophosphamide can be given, and 6 cycles of fluorouracil, epirubicin, and cyclophosphamide can be used. This is the alternative strategy for stage 2 after surgery. Okay. If you see the stage 2, 6 cycles of adjuvant chemotherapy, you can see this. Okay, cyclophosphamide, methotrexate, and fluorouracil. This is 4 weeks, 6 cycles regimen, and along with this, we can also go either with CMF plus TAM, cyclophosphamide, methotrexate, fluorouracil, tamoxifen. Actually, here tamoxifen therapy here, tamoxifen is given after 6 cycles regimen. Tamoxifen is a very important drug. It is this drug after completing 6 cycles. This should be given. Sometimes it should be given for this tamoxifen is given for 5 continuous years. Okay, or it can be given after 6 cycles. Here, tamoxifen should be continued for 5 years or 3 years, 3 years or 5 years. So I will try to explain you about tamoxifen here. See, tamoxifen is selective estrogen receptor modulator. It is a selective estrogen receptor modulator. Tamoxifen is available in oral form, and this tablet is given for up to 3 to 5 years daily. Okay, I think somewhere here, yeah. If you see the pharmacokinetics of tamoxifen, it is absorbed orally, okay, metabolized in liver, excreted in gut through bile, and it undergoes intrahepatic circulation. And if you see the mechanism of tamoxifen, actually tamoxifen has anti-estrogen activities and estrogenic activities. In anti-estrogenic activities, it is showing against breast cancer cells, and in peripheral sites, it causes hot flushes. So common hot flushes is common adverse effect with tamoxifen. And estrogenic actions, it has endometrial proliferation action, anti-resorptive effect, and reduces cholesterol. So about this is about tamoxifen, and yeah, if you see the stage 2 patients, there is one antibody. In few clinical trials, this antibody trastuzumab, trastuzumab is the antibody. This trastuzumab is very very effective, and it is acting against HER2 new receptor. Just previously I told, in breast cancer patients, patient either estrogen receptor is overexpressed, or progesterone receptor is overexpressed, or HER2 new receptor is overexpressed. If anybody has HER2 new receptor overexpression, so in these cases, trastuzumab antibody can be suggested. And this trastuzumab antibody, this is having very good effect in clinical trials to those patients who are having HER2 positive. Okay, so trastuzumab is very important antibody that can be used in stage 1, stage 2, stage 3, and stage 4 who are having HER2 new receptor positive. Okay, and there is another drug, tamoxifen already I explained you. There is another drug for stage 1 and stage 2 under clinical trials which are having good efficacy. Anastrozole. Anastrozole is aromatase inhibitor. It is aromatase inhibitor. This drug, especially in stage 2, this drug should be added along with tamoxifen. I told tamoxifen should be given for 5 years. After 5 years, remaining 2.5 years, we have to go with anastrozole. Okay, anastrozole treatment is also very effective after completing tamoxifen. Okay, So these are having good prognosis in stage 1 and stage 2 patients, particularly in stage 2 patients. Now, if you see the stage 3 and stage 4, just I told treating the stage 3 and stage 4 with surgery plus radiation therapy plus adjuvant chemotherapy. Adjuvant chemotherapy. If adjuvant chemotherapy is given, it has very less prognosis. And usually, this adjuvant chemotherapy, which is given in stage 3 and 4, is palliative. For palliative care, it is given, and these are many challenging. Okay, so here in stage 3 and stage 4, we have chemotherapy with all the different regimens just we have discussed, and along with this, we have endocrine therapy, and some targeted therapies also we have. So in endocrine therapies, if you see the endocrine therapies which are used in metastatic breast cancer, particularly in stage 3 and stage 4, here we have aromatase inhibitors, non-steroidal and steroidal in that, anastrozole, letrozole, exemestane. These drugs can be given, and anti-estrogens. If the patient has overexpression of estrogens, in that we have tamoxifen, torimifene, fulvestrant, and we have luteinizing hormone releasing hormone analogs, in that goserelin, leuprolide, trip, triptorelin. Okay, and in progestins we have megestrol acetate, medroxyprogesterone, and in androgens we have fluoxymestrone, and in again estrogens we have diethylstilbestrol, ethyl estradiol, and conjugated estrogens. Okay, all these drugs are having different drug doses, and they are having the adverse effects like hot flushes. Just now I already told hot flushes, arthralgia, myalgia, headache, mild nausea, vaginal discharge can be seen, mild nausea, thromboembolism can be seen with anti-estrogens, endometrial cancer because they increase the endometrial proliferation. Okay, so weight gain, hot flushes, vaginal bleeding, edema, and again with progestins, all these drugs will cause these side effects. Okay, so these are some endocrine strategies, drugs which are used for breast cancer. Okay, so that's it for today. We'll continue the prostate cancer in next class. Until then, bye bye. See you.